Hello and welcome to the medwireNews podcast. The recent publication of the Rewind study and the Declare renal outcomes have provided some overdue data on people with type 2 diabetes who have cardiovascular risk factors but have not yet had a clinical event. In this edition, we're talking to Kamlesh Khunti, Professor of Primary Care Diabetes and Vascular Medicine at the University of Leicester, about the treatment options for these people and what we can take away from the latest findings. When the hypoglycemia guidelines came out last year, one thing that struck me was that the recommendations were all for people who had overt CV disease at the start. So I was wondering what guidance is there for people who are high risk but have not yet had an event. What's your options for managing them?
So this is becoming a really hot debate at the moment. Who is eligible for these therapies with the evidence base? Previously, we used to say anyone with diabetes is at high cardiovascular risk. But now we're saying with the new trials that if you want to use some of these therapies, then you need to have people with established atherosclerotic cardiovascular disease, or they have heart failure or CKD. Now, it's really difficult to decide from the patients who don't have cardiovascular disease who are the highest risk. We know about 20 to 25% of people with type 2 diabetes will have established cardiovascular disease. In the other 80 to 75%, there is a spectrum of cardiovascular disease who are at high risk. But we have risk scores. We have Framingham risk score, we have the UK PDS risk score, but none of them perform that well in identifying people at the highest risk. And it's not practical to do that in clinical practice. But there are some indicators. One is if you have a low EGFR, below 60, you're at very high risk. If you have macroalbuminuria, you're at very high risk. And if you have both, you're at even higher risk. So that's one of them. The other one is there's a lovely paper that was published in Lancet Diabetes Endocrinology 2-3 years back, which showed that every additional microvascular complication was associated with higher cardiovascular risk. So there was a multiplicative effect of having additional risk factors. Even within cardiovascular disease, there is a gradation. So if someone has diabetes and a heart attack, their risk is twofold higher than someone who just has diabetes. But if you have diabetes, heart attack, and a stroke, then your risk is about eightfold higher compared to someone who doesn't have any of those diseases. There is a continuum, but at the moment we're trying to dichotomize into those with established cardiovascular disease and those without.
Is there any particular guidance for people without cardiovascular disease?
There isn't any clear guidance at all, and a few guidelines are coming out with risk scores, established risk algorithms, but as I said, none of them work that brilliantly in a population with diabetes. So we've got to be really pragmatic about it.
In practice, when you have a patient in front of you, if you know that they've got high CV risk, does that influence your choice of antidiabetic medications at all?
Yeah, now obviously it does now, and that goes with the ADA ESD consensus statement, and I understand that NICE have now decided they're going to look at the type 1 and type 2 diabetes guidelines. It's just announced today, I think, and I hope that they will look at the evidence base, because there isn't any stronger evidence base than what we have currently. People with established disease, you have SGLT2 inhibitors and GLP-1 receptor agonists that have worked well. Until Rewind came out, Rewind and Declare came out, it was only studied in people with established disease or mainly established cardiovascular disease. In Declare TIMI 58, we know only 40% had established cardiovascular disease, the other 60% didn't. But the primary endpoint in that, in terms of cardiovascular outcomes, was beneficial for dapagliflozin in patients with established disease, but not in those without established disease. But heart failure and chronic kidney disease outcomes were beneficial irrespective of people having cardiovascular disease or not. And then the Rewind study, which was just published recently, presented at the ADA in June, they had the highest number of people without established disease, which was around 70%. And they showed that in this population, which was low risk compared to the other there was a beneficial effects in terms of cardiovascular outcomes and a 12% relative risk reduction in the MACE outcomes of composite of non-fatal myocardial infarction, non-fatal strokes, and cardiovascular death. They also showed renal benefits as well, with about 15% reduction in especially development of new microalbuminuria. They also showed reductions in EGFR as well. So we were seeing clear benefits for these therapies in people with established disease. With SGLT2 inhibitors, we're seeing benefits for heart failure and kidney disease, irrespective of people having established disease or not. And with GLP-1 receptor agonists, it seems that they seem to work in people with established disease or those without established disease in terms of cardiovascular benefits, but the renal benefits are again beneficial irrespective of having cardiovascular disease or not.
So do you think the latest findings from REWIND and DECLARE are enough to warrant a shift in practice or indeed in the guidelines?
I think for heart failure and renal disease, definitely. On balance, I would say, looking at the REWIND data, when they did sub-analysis of people with and without established cardiovascular disease, the effect size was exactly the same, the 12% reduction, with no heterogeneity, but they didn't have the power to show superiority for both. So on balance, I would say, yes, they would benefit people without established cardiovascular disease as well, in particular GLP-1 receptor agonists. Real-world data, for example, CVD Real, that does show that people without established disease also benefit in terms of mortality and cardiovascular outcomes. But a lot of people question real-world evidence. I am a supporter of real-world evidence because we know from all these trials that even in the REWIND trial, not all those patients' population would be representative in the real-world setting. Only about 50-60%, I think, were in the REWIND, which is probably the most inclusive trial there is. Real-world data is benefits, and maybe because these patients are sicker patients, and some of these trials are showing that patients who have a low EGFR seem to benefit more.
I've been hearing quite a bit recently, sort of people arguing for these cardioprotective drugs to be brought in earlier in the pathway. For example, one of the DECLARE investigators saying that we should be treating sort of at the hyperfiltration stage in terms of renal function. So is that something that you would like to see?
Well, I think there is an issue with injectable therapies, so you might not get a buy-in from patients and even healthcare professionals of starting those early, but oral medications certainly. And I think we will know within the next 2 or 3 years about the beneficial effects of SGLT2 inhibitors in people without diabetes. And a feeling out there is that they may be the next ACE inhibitor. The other issue, which is, as you know, of interest to me, is that we do have fantastic trials. We have really great therapies now to use on patients that we feel they may be appropriate for. But we still have this gap in terms of translating the evidence into clinical practice, the so-called issue of therapeutic inertia. And I think it's been 10 years now that we haven't really improved our outcomes in terms of HbA1c for our patients. However, now we're in a different paradigm that it's not just HbA1c we're talking about. We're talking about here improving the lives of patients, and these therapies really should be used much, much earlier. And until the NICE guidance come out, I think primary care in particular are reluctant to use them, except for people who do know about these trials and who are doing diabetes care on a daily basis.